Oops. All right, I'm gonna give everybody just a minute. All right, I'm gonna give everybody just a minute to get logged in, and we will get started in just a moment. But as you guys know, my name is Ginger. I'm the Executive Director of Connectionology, and we are very excited to have you with us today, especially because we're talking about a very important subject. And you're going to be hearing from Lyn, Jamie, Dr. Kiehl, as well as David, who will be coming in shortly to meet us. And then later, you're going to meet our amazing partners over at OnPoint Legal Nurse Consulting, Fox AE, EmotionTrac, HMR, as well as Brain Mapping Solutions. And if you have any questions, I encourage all of you guys to put those in the chat box today, so that way we can have like an ongoing dialogue in the chat box. And if you have any questions, of course, let me know. But I will also make sure at the end of the webinar that you get the contact information for all of our speakers as well. So let's go ahead and get started because we have a lot we're going to be covering and talking about. I'd first like to introduce Miss Lyn, who is an attorney with a private practice in New Mexico, and it's called LK Legal. She specializes in medical case management and client relationships in traumatic brain injury cases. And she works with attorneys and firms all over the country to help them improve their intake process. That includes TBI, and she helps manage individual TBI clients, as well as ensure that they get proper treatment, as well as maximize their recovery. And Lyn has also spoken on a lot of our seminars before. If you've ever been to Santa Fe, she came to several of those and others as well. So we are just so honored to have Lyn with us today, helping moderate. And Lyn, I'm gonna hand it over to you. And I hope everybody has a great webinar.
Thank you so much, Ginger. Well, I'm absolutely delighted to be here today, and I have probably the best role I've ever gotten to have in one of these webinars is that I get to introduce our two distinguished speakers today. And so Jamie Holland, I feel, needs no introduction to attorneys that are here, and he will not let me read his very long bio. So I've just come up with a very short version of it. So Jamie is just very well known for his work in trial advocacy and mentoring of young lawyers, which is just so incredibly important. And he's received many accolades and awards for that work. He's very involved in the Florida Association for Justice and also the AAJ, the American Association for Justice. And before Jamie and I ever had a chance to meet, I knew of him because I learned about him through attorneys that told me what an excellent job he did representing clients with just not only brain injury, but basically major mental health conditions. And so things like PTSD and sort of the kind of emotional and psychiatric consequences of these injuries, and how he was so knowledgeable about those conditions and that he represented those clients really as well as it could be done. So thank you, Jamie, for sort of being the one to bring this together today. And the other speaker is Dr. Lyn Kiehl. And who happens to be my husband, and that is conspicuously absent from the bio that he gave me to read today. So I will go ahead and add that. So Kent is a neuroscientist and a professor and an expert in many, many things. So for most of his career, he's done clinical neuroscience research in major mental illness, and this ranges from substance abuse, psychotic disorders, PTSD, and including TBI. And he's published over 250 papers. He's received more than $50 million in NIH funding over the course of his career. And for his papers, if you email him and ask him to send you a paper, like I do occasionally, he will frequently redirect me to PubMed rather than try to dig it up himself. So seeing as how he won't email me, the papers, you all are going to be on your own as well if you want any of the papers that he cites today. So I am now going to turn it over to our speakers, and Jamie is going to sort of help moderate Kent's talk and lead the Q&A, and I will be interrupting when we have some breaks to hear from our partners, but I will sign off and let you two get started. Thank you.
Great. Thanks, Lyn. All right. I never want to go before a doctor, particularly on a subject that's mostly medical. Now, for every lawyer here, I know you've had a PTSD case, or if you don't have one, I suspect if you look more carefully through your client list, you'll find one. And the difficulty is, we're getting to the point where TBI is suddenly a very provable injury with the advent of MRI DTI. I think, largely based on the work of Dr. Kiehl, we're going to be there with PTSD in just a few years, um, so long as the approach is done correctly. And that's part of what the talk is today, on how to do it correctly and how to get there. But the science is catching up with PTSD, just like the MRI DTI caught up with TBI. And with no further ado, let me turn it over to Kent. Kent, first of all, tell us, we all hear PTSD from a doctor's perspective. Tell us what it is.
Right. So I'm going to, thanks, Jamie, and thanks, Lyn. It's the first time I've been introduced by my wife. We're gonna talk about all of the symptoms today of PTSD and its evolution as a construct, as a disorder that's recognized, by our American Medical Association. We're going to talk about some controversies in the diagnosis, some challenges, some difficulties, what people are likely to probably hear about and cross, or have differences of opinion, that can reasonably be occurring between two experts. So we're gonna dive into, probably more than most people want to hear about, the various symptoms and the evolution of the construct. So Jamie and I have decided that we'll go ahead and take questions during the presentation. So if I talk about something that you would like me to cover in more detail, or please feel free to insert a question or chat, and Jamie will help to interrupt and moderate during the course of this. So very happy to take questions as we go along. And so I was asked, to help create this presentation. And as I was, developing this talk, tried to cultivate, some of the central things. And a lot of my career, last 10, 15 years, has been doing a lot of judicial education. So helping educate judges and attorneys about how neuroscience is going to be introduced into the courts, how it's going to be, how it's going to come forward, and what kind of pretext. And so today, we'll focus on a variety of different areas, but with a specific focus on post-traumatic stress disorder. The condition and the recognition of the condition of post-traumatic stress, really was precipitated through world wars throughout the centuries. And from World War I, we had people would refer to individuals as either shell-shocked or having the so-called 1,000-yard stare, where they would be staring out almost in a dreamlike state, and very much struggling with everything normally going on after these types of conflict. In World War II, came up with the term called the combat stress reaction to the types of atrocities and things that you see during combat. Association really first recognized post-traumatic stress disorder in what's known as the DSM-3, or the Diagnostic and Statistical Manual for Mental Illness, the third edition, which was published in 1980. And in addition to recognizing that these types of the symptoms that we'll get into can come from war, there's a very clear appreciation and now that many other types of experiences, traumatic experiences, can lead to the same or a very similar cluster of symptoms, including things like sexual assault or severe physical abuse, domestic abuse, experiencing natural disasters, especially unexpected ones, very different types of violent crime, for being a victim of violent crimes, and car accidents and other things. Any kind of trauma can contribute to the development of these systems. We know that about 8% of the population at any given time will have PTSD as a diagnosis. About 1 to 3% continually new each year. One of the nice benefits of our contemporary psychology and neuroscience is that we're able to actually, PTSD is a fairly treatable condition. In fact, some have argued most of the symptoms are probably, some of the, as psychiatric disorders go, PTSD is one that we really are able to, in a conjunction with psychotherapy and medicines, really help patients. And so that's one of the big benefits. There is a sex difference. That is, women have about twice the chance to develop these symptoms as men. That number is a little bit challenging in the sense that the studies that report those numbers, men don't like to show up at psychiatric appointments. Men don't like to go tell people about the struggles they're having. And they do so, I mean, women might not like to do it all the time either, but I think that we definitely have lots of evidence that men don't do a lot of treatment seeking. They don't like to go talk to somebody, see somebody, and report these types of things. So it might be a little bit closer to, maybe a 10, 15% difference, not necessarily a doubling, but that is the current kind of epidemiology. That's what your experts will talk about if you bring someone in to discuss kind of the rate and overview of PTSD. So as it goes, it's very common. It's an extremely common condition, and most academic facilities, clinical training programs, psychiatric training programs are going to have experts that work and focus on PTSD, whether that's with veteran populations or with other civilian populations. It's a very common and popular condition as these things go to be trained in. So experts are common and usually very easy to find.
Let me ask you this, Ken. We've got a question, and here's the question, and I think it's from Stacy Martinelli. Do you feel that PTSD can be caused by secondhand or vicarious trauma as well? I'm assuming that is either hearing about the trauma or experiencing the aftermath of the trauma, even though you have not been an actor or an experiencer in it.
So the answer is yes. And the next slide, actually, we'll talk about this. We can talk about that in a little bit more detail. So individuals, for example, that are hearing about trauma or are, for example, even seeing things vicariously. So police agents who are, reviewing stimuli of child pornography or crime scenes or other types of things in order to help with their cases can develop and have difficulty, processing and struggle. And so but in contrast, things like watching movies. So if you watch movies or television or other things, unless it's like a mandatory thing that's required by work, it's exclusionary. So we don't give PTSD diagnosis right now for exposure through that type of media, Instagram, Facebook, those types of things. And that might change. Again, these are criterion that are current, and but it's necessary that there is an event that triggers the development of the symptoms.
And I've got a real world example of that. Unfortunately, it's fairly fresh. I had the opportunity to talk the other day with one of the rescue responders to the children's hospital in Kiev. And she was telling me what she was experiencing. And it's, if I went down the DSM checklist, it was PTSD, nightmares, hypervigilance, startle response. She had everything from PTSD, and the triggers were all very connected with trying to rescue kids from the children's hospital. Is that an example of what we're talking about? Okay.
Yes, absolutely it is. And that's one of the more common, wartime scenarios that, especially when it's, might involve children or vulnerable populations, that it can contribute to the development of these symptoms. Absolutely. Okay. So I have my AI generated psychiatrist here picture to just try to highlight that I'm going to present to you now. Probably might be a little bit, I don't usually present a lot of text when I give lectures and talks, but I think that it's illustrative of the complexities of this condition to just kind of highlight the symptoms and how clinicians have to go through and assess post-traumatic stress disorder. I've highlighted in the next few slides in red the text that is the take-home text that I would like everyone to kind of, just kind of peek and review. But the rest of it is here for, your subsequent review later. And so the current version of the Diagnostic and Statistical Manual for Mental Illness number 5 with the text revision, that's the -TR, has a variety of criterion that are necessary for a patient to meet PTSD. And it goes from A through H. And criterion A is what we just spoke about, which is the exposure to actual or threatened serious injury or death or sexual violence. And so some type of an event has to have precipitated the symptoms. So the symptoms, if they're particularly relevant to a legal question, so some sort of an event, then they can't have been present prior to this event, or you would contribute that to a prior earlier event. Of course, polytrauma, or having been exposed to many different types of traumatic events, is common. And in the forensic populations that I work with, it's the norm. The average forensic, or inmate that I've worked with over the years has 3 or more traumatic events that have, on average, been reported or documented. And so this polytrauma is sometimes more the norm, which complicates, sometimes the assessment of the contribution of each individual trauma to the client that you see today. But it's always going to be that combination of different things that leads to the person that you're seeing today.
Ken, going back to criterion A, number one is, has there been a change from DSM-3 through 4 to 5? Tell us about the change in criterion A, and let us know how that has developed, because it's different than it used to be 20 years ago.
It's totally different. And I do have, actually, you're anticipating the next slide. So I have a couple of slides that talk about how different it has been. And generally speaking, there's been a massive growth in the number of papers and publications and symptom assessments that have led to the changes. But we'll talk about some of the challenges with the DSM when we get to the next one. So let's jump over to B. So the criterion B includes these intrusive symptoms. So things that are penetrating and causing distress, whether that's the memory of the event, you're having distressing dreams about reoccurring with the events, or flashbacks. These things cause difficulty for the client. They cause a significant amount of distress, and especially cues can also list it. So seeing a car accident, having been in a car accident, for example, if that was the event, then seeing other car accidents, being around cars, all of those things can contribute to cognitive distress. Marked reactions as well to both internal and external cues. If your heart rate went up when you had the event occurred, and you feel yourself heart rate, you can end up with almost like panic level attacks and things like that can happen. So these intrusive symptoms are very common, are a necessary part of having developed the criterion or the disorder. Criterion C, avoidance. The clients will avoid anything that is going to remind them of the event. So this could be things like not going to the locations, not having conversations, not doing activities that remind them of the event, avoiding certain places, etc. And so there's a clear evidence of avoidance of certain stimuli. Criterion D involves changes or alterations, typically negative, in cognition and mood. And so that's thinking and emotion. And so basically the event has caused a significant alteration in the normal functioning. So this is going to cause problems with memory and unable to remember certain aspects of the event. You're going to have sometimes negative beliefs about the client will report that maybe it was my fault. I did something bad. I contributed to this. They can have distorted thinking about the cause or the consequences that led to the event, blaming themselves versus blaming the person that caused the violent crime, for example, to them. Negative emotional states, and look at the number of different types of symptoms: fear, horror, anger, guilt, shame. There's a lot of different issues. And again, people will start to detach from and estrange themselves from others. They can often be homebound or not wanting to leave the house. They also suffer from like anhedonia, so they might not necessarily, a little bit of depression. They might necessarily be experiencing emotional positive things in the same way. They won't be as effective. And so you can see that the panoply of symptoms that you see are extensive and complicated and markedly cause problems. We also see criterion E, marked alterations in arousal. Jamie just mentioned hypervigilance or a big startle response. So the startle response really gets exaggerated. When I was at Yale University, we worked with a group of men who had just been combat exposed, and a group of men combat exposed but with PTSD, and then a group of men who were just non-combat exposed but currently active military. And when we were scanning them and studying them and using MRIs to study how their brain process stimuli, we gave them some little trigger stimuli, little probes that basically asked them to respond to something that was really kind of salient and important. And I'll never forget just how reactive the neurobiology, the neural circuits were of the men that were combat exposed and reported these PTSD symptoms. And so it's a very, just a very common kind of experience to see this type of startle related response being exacerbated. But this is, again, criterion E is about hyperarousal, hyperreactivity, often irritability, anger, other types of things occurring. Sorry, somehow my music started playing in the background here, so I'd correct that. Sorry for that. So my marked reactivity. Okay, now if you thought we were done, we're not quite done. There's still a few more things that your expert has to assess. And one is that these things don't, they have to be present for about a month at minimum. They're often much longer lasting than that, but they have to have been present or seen for more than a month to meet criterion F. It has to cause distress. And so this is one of the things that people disagree about most, is how to assess whether or not this is clinically significant. So, generally speaking, if you have a significant amount of distress, it's going to impair your work, home, sex life. It's going to impair relationships with family and friends. And you're going to see that there's a change that has occurred from the incident and to this impairment in occupational and other types of importance in life. And then, of course, you all know that PTSD is associated with drinking or alcohol and sometimes other drug use. There often can be on medication, so those can't be the cause of these symptoms. So that's an exclusionary thing. Now, if you thought you were done, we're not quite done. There's still one more, and I know this is a lot. So we have this recognition, I've put this in here, that sometimes like the 1,000-yard stare, you will get symptoms that are dissociative symptoms. And this is not present in all patients. And so you get sometimes individuals that have feeling like they're in a dreamlike state or a perception that they're out of body, kind of a dissociative process. And those patients, that they're usually a little bit different. They're going to actually, many research studies suggest that there's different things going on in their brains that are different than patients with other types of PTSD. And so that can be a very important distinction. But I just wanted to give everybody, those are the full kind of criterion. And as you might expect, as the condition has evolved, there's been challenges or criticisms. And this is one of the reasons why we use other methods like imaging to try to help study and understand, are these symptoms causing alterations in the brain, alterations in brain activity, that we might be able to help kind of interpret or understand that when somebody has a condition. So I can tell you that there are 600, and the paper is pretty famous, 636,000 combinations of items that you can have in the PTSD symptom list that I just gave you to achieve a disorder. So that is a problem. And this paper kind of summarizes, I think you should be able to see my mouse here, that from the DSM-3 to the 4 to 5, the possible numbers of combinations of symptoms just went nonlinear. I mean, it really, really, really grew. And so why would that happen? Well, it's a recognition of the complexity, and the word we use is heterogeneous presentation of the wide variety of different symptoms. And the challenge, but that presents with many challenges, because there's probably not 636,000 different disorders going on inside the head, or different systems or circuits. And so it can be very much then a contentious kind of diagnosis when it's so heterogeneous and challenging to diagnose. The DSM-5 is also routinely discussed in academic circles and in National Institute of Mental Health circles as an instrument that's really most useful for insurance purposes. So if you have a client that meets the criterion for PTSD, that enables you to get them a CPT code and get them insurance and get them on a treatment part. So it's better to err on the side of being careful and getting someone into resources, or availing themselves of resources in our medical system, rather than not, if they don't have a disorder. And so we see this pretty much across the board in a lot of different psychiatric conditions, is that it has become, if anything, a little bit easier to meet criterion in order to allow people to avail themselves of the resources that are needed.
Kind of.
The NIMH even went so far. Yeah, sure.
Oh, sorry. It's actually going back to the last slide. I've got a question. Would individuals experiencing PTSD-induced psychogenic, non-epileptic seizures fall into the dissociative subcategory?
Um, so yes, usually if you have somebody that is having seizures associated with an injury, obviously a mild TBI, if the symptoms associated with that are going to be disassociation, that is feeling like they're in a dream or not feeling like they're intact or they're outside their body, then that would fall on the dissociative side of things. Yes.
Okay, and that's going to be I'm assuming if you've got a TBI and a PTSD, that's going to be a hard differential tree to figure out which one to attach it to, if not both.
Right. So the PTSD diagnosis is really much a symptom-based, diagnosis. Um, you would if you have somebody that is, has a very significant brain injury in conjunction with that, they would be likely both, right? You would have TBI secondary to these PTSD symptoms, both of which, of course, are completely relevant to their legal, outcomes, is to assess both and to looking carefully and examine both. And we'll talk about TBI because it is so common. But what I wanted to just highlight is that the DSM is in a legal framework, it's an absolutely necessary tool for your experts to use to help establish that a client meets criterion. But to be aware that they're going to often be very contentious and reasonable debates about how people assess and do things, given how much change occurs over the time and how we decide and come up with whether or not somebody does suffer from an illness or has a condition or disorder. The other thing I can tell you as a researcher who studies these things, the National Institute of Mental Health, part of the National Institute of Health, a few years ago, maybe a decade ago now, when the DSM-5 came out, they actually banned researchers from using the DSM-5 in NIH-funded research. And the reason why they did that was because they felt that the DSM had been used as had moved from a tool for researchers to a tool for a community or people in the community who needed to have somebody set up with a diagnosis. The diagnoses had changed so much, had become so easy to meet criterion, that it wasn't something that they wanted researchers doing. They wanted researchers to go far beyond. And that is what led to a lot of us developing and doing the imaging methods and the imaging analysis of the MRI and other data that we'll talk about a little bit before. But I always like this contrast though, when you look at like what has changed, if you look at things like, phobias, all right, I've got a snake phobia. That's the only thing that hasn't changed. That snake is still a snake, and that snake is still what triggers my phobia. And so I only have one symptom. I'm afraid of the snake. So specific phobias are really easy to diagnose, and they really don't have any complications associated with them. Whereas other conditions like panic disorder, you can see that it's gotten narrower. It went up, it got broad, and then it came back. And so that's more of the exception than the rule. We generally see most conditions are tending to become, it's easier to meet criterion because we also have more medicines that people are trying to use for them. We have more, and again, it's mostly for this type of thing. But I just wanted to kind of highlight that this heterogeneity is the common thing. So there can be, the trauma can cause many different things to go different, if you will, in the brain. And those differences then manifest as a wide variety of different symptoms. Okay. Now, there are obviously things that can increase the risk for a client developing post-traumatic stress disorder. So if they previously had an illness or previously had been hospitalized for some sort of mental health illness, that'll be increase their risk. Obviously, I've mentioned already that women have a greater probability of developing PTSD from the same event compared to men. Certain personality traits, certain socioeconomic indicators, poor education, poor diet, other types of things can contribute to an increased rate or risk. And then some other things, a previous history of trauma. So like I mentioned, polytrauma is the rule. And if they've had multiple different exposures before, that will increase the chances that they're going to develop the condition again. And then the hippocampi, that's a neuroscience, that's an area of your brain where memory is stored. And if for whatever reason you happen to have a smaller hippocampus than normal, than average, I guess, then you are at increased risk for developing post-traumatic stress. And so there are these types of factors that experts have to kind of consider when they're working up their assessment and their diagnosis about post-traumatic stress disorder. Now, of course, PTSD is also commonly associated with a variety of other types of conditions and issues. Depending upon the population, upwards of half to 3/4 of patients who develop PTSD also have a traumatic brain injury, a mild traumatic brain injury. So it becomes very important to be able to assess and understand the interplay between those two conditions and treatments of which are going to be potentially very different. But you can see that there's a wide variety of different other symptoms and conditions, especially depression, anxiety, that can come along with post-traumatic stress disorder, and sleep problems, anger management, substance use is also one of the bigger issues that comes up as well. All right, so this is just kind of a brief summary of the symptoms and the assessment, of PTSD, the challenges that experts are faced with coming up with the groups. The current kind of contemporary research looks at clusters of symptoms. That is, do patients with these dissociative symptoms differ in their outcomes, in their treatment needs, in their medication needs? Do they need longer hospitalizations or different lengths of hospitalizations? And all of these things are kind of actively being studied pretty much in most academic sites around the country. What I'd like to do now is I'm going to turn and talk a little bit about the brain imaging and how brain imaging data might be helpful for informing of both TBI and PTSD. Jamie's already mentioned a little bit about diffusion-based imaging. So one of the things that my laboratory does is we use this unique mobile MRI system. So yes, I live in New Mexico and I have a trailer, and this trailer has a very nice magnet in it though. And that magnet roams around to various forensic sites, from psychiatric facilities to prisons. It's been, all over the country. In fact, one of them is currently in Ohio. The other one is currently in a facility here just outside of Santa Fe, in a maximum security prison, level 6, the highest security in New Mexico. And I study a wide variety of different, conditions that happen within forensic populations. This machine, like most MRI machines, is capable of collecting a wide range of image modalities. So I'd like to talk a little bit about these different modalities. So this is all from the same MRI system. That is, if you go get a good academic 3T MRI scanner, it can be set up to acquire all of these things without contrast, without anything else. 1.5 Tesla or 3 Tesla or 7 Tesla are kind of the common field strengths that are used. By far and away, the most common is the 1.5 Tesla. 80% of magnets worldwide are 1.5 times the Earth's, or 15,000 times the Earth's magnetic field, but 1.5 Tesla. 3 Tesla is probably the ones that you're most commonly getting today if you're working with imaging. That's become kind of the stable workhorse at academic sites and more advanced radiological groups. 7 Tesla is now even possible. There's quite a few academic institutions. It's FDA approved. Siemens 7 Tesla scanner is FDA approved, but most of them don't have the reference databases or other things that you would be expecting for the type of psychiatric work that we're going to talk about. So this is an angiogram. You'll probably see this commonly if you have any risk of stroke or if there's been any kind of a damage to the arteries and veins in the brain. And these are really helpful for determining if there's bleeds and other types of problems. And that can just be collected today on a routine scanner in just a couple minutes. This beautiful picture here, this is a picture, I've had people say, do you have blue wires in your brain or whatever? No, we don't have blue wires. These are the beautiful colors that neuroscientists like to use. They indicate the direction that the white matter or the connective tissue in the brain is moving, either up, back, north, south, east, west. So we love that, very colorful, beautiful pictures. But this is a technique called diffusion imaging, or we can use different ways of quantifying. And it's basically a measure of the integrity of the wires in the brain. So water moves along those at the molecular level, and we can tug and pull and study that. And if you take and twist this, the brain is very gelatinous. Then one of the common issues in brain injury is when you twist when the mechanical forces cause the brain to slosh in the head, or from an external impact, then that can lead to these wires breaking a little bit. And we study how those little breaks influence things. And it's very common to use this technique today in civil cases and as well as criminal cases to try to help understand the influence of mild TBI. The image over here, again, you don't have red spots on your brain or anything like that. This is a map that shows on a rendering areas of the brain of the working brain. And this is a technique called fMRI. It was invented or discovered really in about 1990. And it's a very popular technique in neuroscience, and it measures neuronal oxygenation changes. So just like your muscles, when your brain is working, it consumes oxygen, and we can measure where that consumption takes place. This is the so-called fMRI technique. We're going to talk a little bit about it some more. Most MRI scanners, what is it used clinically? So if you have a tumor and you are going to go in and get, the surgeon wants to remove the tissue around the tumor to try to make sure it gets everything, all the cancer, then they might do a functional MRI to measure how you read, I know how you think, how you do math, and are those functions around the area that the tumor exists? Because they'll be more careful if your eloquent cortex, your so-called language cortex, language generation, speech production, is near that area of the tumor, they don't want to remove your ability to speak or talk or chew gum. The quality of life is very low. So this technique is used in clinical service. There are CPT codes, but I would say it's probably not going to be available on most MRI scans. You do need to go get a very specialized place. And it's not trivial. I teach, a whole semester on how to analyze the data, from fMRI. And, it takes 8, 10, 12 weeks just to get students, through the general, to make those beautiful maps. There are other, but I guess this is a structural exam, a typical one. Everyone has seen a picture of an MRI at this point. But what we can do is we can take all of these different images, and we can subject them to quantitative analysis. We can subject them to methods to analyze their volume, their density. We can measure the time course, the connectivity between different areas. We can measure a wide variety of different things. And most of these techniques are matriculating into the criminal justice or civil system. And it's a very common thing that you're seeing today. And so today we can talk about anything. Questions can come about any of these different techniques or issues. I'd be happy to talk about any of them. That's where I spend most of my days analyzing this type of data. So, my lab, just to touch a little bit on the background in my team. So we've scanned thousands of inmates. We study everything that goes wrong or is potentially at risk. And for our talk today, post-traumatic stress disorder is present in upwards of 25 to 30% of inmates. And so it's an extremely important construct for the criminal justice system. Developing and implementing treatments and other resources are very important. And so we study, like, how does the brain change with treatment? How does the brain change and get better over time following a TBI? Upwards of 50% of all inmates have had a mild TBI. And so out of necessity, we have come to really try to develop and understand how these issues that happen in forensic populations in very high numbers of high rates, can we develop and help to reduce the chances that people will continue to get in trouble and reoffend. And if you Google me, you're going to find out that I study psychopaths. I study them as one of the primary areas in my work. And so we're probably not going to talk about psychopaths today, but I'd be happy to come back if Jamie wants me to talk about psychopaths. All right, but anyway, so this is kind of the database and the templates and the things that we work with. As you guys have seen, when you come in and you get an MRI scan, often in cases like this, the MRI will illustrate visually that we have an injury. So this is an example of a gliosis and cell loss from an injury from a TBI. We have this little white matter speck here. That's called a UBO. In some places, or unidentified bright object, that we like to call them UFOs in New Mexico, but that's a UBO. And that can be from the trauma, or that could be for ischemic disease or any number of different things. But this is clearly from an old injury. And so most of you have seen that. If you had a client that you scanned and that was what you saw, then that's probably going to be what you're going to use in your proceedings. You're probably not going to even need to do anything other type of quantitative imaging. Similarly, here's an example of another client that had a head injury, and that caused an impairment down here in the thalamus. The thalamus is an area of the brain that is associated with processing all sensory stimuli. So this patient would likely have symptoms of sensitivity to brightness or noise, and would struggle, with those types of things. But that's evidence, again, of a clear kind of injury. When we talked about diffusion, I'm just going to review quickly because Jamie already had a nice segue into this. When we want to measure these beautiful, the intricacy of the white matter of the brain and how the white matter of the brain is when it gets injured, we and others have published many papers showing that you can quantify injury in the brain following TBI. In this example, we took about 80 men who had had a chronic mild TBI, often many years from injury, and we compared them to 80 men who did not have any history of mild TBI. And we use these advanced artificial intelligence, we call them machine learning classifiers. These systems, what they do is they learn what differentiates the two groups, and they iterate and they go over and over and over and over and over again until they identify a formula that maximally separates the groups. And then it goes back through and it says, I can correctly do this based on the data set about 85% of the time. So I'm able to correctly classify that this brain is injured or this brain is not injured with that high level of confidence. One of the challenges always is what's the ground truth in these examples. So years ago, we developed a concussion protocol for using MRI for student athletes, and it was publicized and on the web, and my sisters noticed that I had said on Facebook or something that I have had several concussions in my life. And they wrote right away and said, you had 3 before the age of 5. And so of course I don't remember. Of course I don't remember those. And so it's often the case that when you're developing and you want to compare someone with a TBI to a control group, the control group may not remember that they were also had a TBI. So 85% correct classification in the absence of a perfect ground truth is extremely good. And so this is the type of kind of what we look for when we're doing a research or writing grants, is that level of classification is always going to result in a nice publication. And this could be translated into the future. I think you'll start to see these algorithms be used in courts because the math is excellent, and it really takes away, and it can be automated so that it can be kind of a completely objective. You don't need anybody to come in and do any additional interpretation. The classifier basically says that they match this type of a group. So the other technique that we've talked about already is this functional MRI technique.
Hey, Ken.
One of the
Ken? Sorry to interrupt you, but we need to take a quick break.
Okay.
To let one of our partners in. So I was trying to get you before you switched to a new technique. So sorry, I didn't quite.
It's a good time.
Okay,
it's a good time. Do you need me to stop share?
Yes, but
Yes.
I tell you what, this
Okay.
this is already giving us a peek into some really exciting stuff. So I cannot wait to get back to this. We're just going to take a quick break just for a minute because I wanted to bring in our good friend Ingrid. I believe Ingrid has been a nurse for, I think, almost 40 years. She's going to correct me in a minute, but she has been in the business for a very long time. She's with OnPoint Legal Nurse Consulting, and she is fabulous. She usually speaks on a lot of our nursing home abuse webinars that we do, and it is just such a pleasure to have her with us. Hi, Ingrid.
Hi, how are you?
Thank you for joining us today. It really means a lot to us.
Well, thank you for having me. And this is fascinating. And I don't, it seems that much of the world probably is suffering from PTSD these days. And I want to know how Dr. Kiehl manages not to develop it, but studying all these psychopaths. But I did read your bio and it's fascinating what you do and hearing about this. I've been a nurse for 40 some years. I've stopped keeping track, but I have a master's in gerontological nursing and came on with Mindy Cohen many years ago to do expert work and have morphed into managing the geriatric program with OnPoint Legal Nurse Consulting and Expert Location. I work with Patrick Stonich that you've seen on many of these webinars. He really specializes in assisted living, group homes, and home care and hospice. But I have a whole bunch of nurse, physician, therapy experts that we work with to manage nursing home and hospital, et cetera, cases where bad things happen to older adults. My other colleague is Dawn Montagno. She manages all of the expert location and pain and suffering and consult cases related to non-geriatric cases. We do record retrieval and record organization. We do merit screens verbal or crons and summaries, pointing out strengths and weaknesses. We do a lot of expert location all over the country. And we sort of are one-stop shopping. I think that what makes us special is how quickly we respond, how quickly we get you what you need, how likely it is that you'll pick up the phone and call us and get to talk to us, certainly within the same day, if not the same minute. Pass us by what's going on with your case and what you believe you need. Sometimes we actually can figure out maybe that's not what you need, and you need a different type of expert. We're here, phone, email, depth preparation, trial, exhibits, whatever you need from A to Z, we can help you with it. So please holler if you need any help. We're here. And thanks for this great presentation and for including OnPoint. Thanks.
Oh, it's an honor to have you guys with us. And as you know, John Romano, he raves about you guys' pain and suffering reports. So they are so thorough. And I would say if you guys have any questions for Ingrid, please reach out to her because she is a wealth of knowledge and she can definitely help you guys out with anything that you need.
Sure thing. Thanks.
All right, Ingrid, we'll hopefully have you soon, speaking very soon for us soon, okay?
Okay.
Ginger, will you put Ingrid's contact information in the chat for everyone?
Absolutely.
Okay,
Absolutely.
great. Thank you.
All right, and now back to Dr. Kiehl.
Great.
I'm here. Let me work on the
So Kent, when
PowerPoint.
you start sharing your screen, there's a question about your golf clubs and if that's PXG.
Oh.
I can answer for yes, he plays PXG clubs. And if
I
we ask him,
do.
he will talk about golf the rest of the time. So we're going to need to hold that till the end. Because he's a huge fan. The question was, is golf a good stress reliever? And I feel like golf is your favorite thing in the world.
I like to play with people who are just a little worse than me so I can take their $2 skins on every hole. But yes,
Golf is a stress creator for me.
Golf is one of my main stress relievers. All right, let me put the play from here. Let's see if this loads up and then I'll share again. Where'd you go, Lynn? Hold on, Zoom. There we are. Share. I have a couple screens here, so that should work. How does that look, Jamie? Does that look back to normal?
Looks good. You're back to where we were before.
Great. Well, thank you, everyone. So what I'd like to just talk a little bit about today is this this new technique, or relatively new technique, that we use, which is called functional network connectivity, and it's a way that we try to quantify normal processes and abnormal processes in the brain. And so if I have these 4 little areas of the brain, they're color coded with those dots there. Each of those will have its own signature, its own hemodynamic, pattern. And sometimes what we'll find is that in this example, those 4 dots are correlated in different patterns together. We would call that a measure of connectivity. They're connected. They're showing relationships to one another. When one's going up, the other's going down, for example. And so they have a net. They form a little network. And it turns out that these networks are dynamic. And so the networks in the brain shift back and forth depending upon what you're doing, of course. And they naturally will evolve into various different states. And this changing in the states is called dynamic connectivity. That's a fancy word for saying that these different networks of the brain are doing things differently. And when you have a psychiatric illness, something like PTSD, that has all of these various symptoms, these networks, these states, interact differently. They interact differently with one another and they get disturbed. And so you can imagine that depending upon the symptoms that the patient's experiencing, these network states will be different. So we can develop models of this is what's a normal network state. These are things that we see in someone that's healthy, that's non-injured, and doing very well, for example, a control subject, so to speak. And then we can tile and identify what are the patterns that differentiate different patient groups. And my lab and many in the world use this technique to help discriminate different patient groups. One of our first papers looked at this technique. Again, this is an analysis of, it's an fMRI technique, a functional magnetic resonance imaging. Oops, yes, there it is, good. And what we found is we studied with these advanced machine learning algorithms can it learn to discriminate someone who's concussed from someone who's not? And basically, static connectivity gets about 80% correct. Fractional anisotropy, or the diffusion, is about 75% correct. But the dynamic connectivity was achieved the best classification, over 85%, accurate. And it's these long-range connections between like the motor coordination system in the back of the brain down here in the cerebellum, and the motor system balance is one of the single biggest issues that's disrupted in concussion. And it's reflective in how those networks were connected. And so it's very predictive of the type of symptoms the patient's going to be experiencing, et cetera. And we've used this in multiple different psychiatric neurological conditions to help illustrate that it's extremely sensitive. This is now, this connectivity analysis is slowly becoming part of the legal repertoire for attorneys looking to use and leverage this science. And I'm going to highlight some of the other studies. This example that I highlighted again here was from individuals who were in a mild TBI. Most of them were in some form of a car accident. And again, it's showing extremely high single subject classification. One of the things we like to do is we like to try to combine the gray matter, the diffusion data, the functional imaging, and perhaps like spectroscopic imaging. And we put them all together into a big, what we call a multimodal analysis. And we can then help to achieve, hopefully, a very precise understanding of the injury or the psychiatric condition that the patient's experiencing. And so most of the state-of-the-art grants are going to be looking at that. Yeah, was there questions?
No, actually, just you're in presenter view, so people can't really see the slide well. So I don't know if you can change your screen share so they're just seeing one slide.
Yeah.
Thank you. Okay, I just wanted to.
Yeah. No, it's good. That's sometimes what it does when it's on. Let's try to do that again. Get it on the same screen. So play from here. And then if I go back to you in the Zoom and you're here, then now it should, let me make sure I share the right screen. This one. Is that better?
That's better. You're out of presenter view and now in just present.
Okay. So great. So for those of you that didn't see, this is kind of just this highlight of this network connectivity. And it just kind of illustrates that it's an extremely sensitive technique to disruptions associated with TBI, and you'll soon see with disruptions associated with PTSD. One of the things we like to do in academia that provides kind of the proving ground, if you will, for psychiatric conditions is we aggregate data from many different places. And we try to learn whether we can generalize our results from different sites, from different countries, from different places. There's a big consortium. I'm a member of several of them. One of them studies post-traumatic stress disorder. It's called the Enigma Consortiums. And in this study, they had over 3,500 patients in controls from 20 places from around the world. They used these advanced machine learning, artificial intelligence classifiers to try to work on a variety of different types of MRI data. So they took structural MRI data. They used a common technique it's called free surfer, but it parcellates the brain into different ways. They did some connectivity. We used a different technique that we think is a little better than this, but they used one technique that's popular as well. And then they used FA. They used this, track-based spatial statistics. It's called TBSS to measure and quantify the white matter. Unfortunately, what this study did was it didn't find the really high levels of classification that we would hope. They got somewhere around 55 to 78% was the highest levels of classification for just a single site. And what's important is that the conclusions that they drew were about how important the control. Well, first, that there are differences between site that are really challenging. So if you're going to be scanning somebody that's a client in Florida, and you're going to be comparing them to a database that was collected in California on a different scanner, there are significant numbers of challenges that it presents in order to do that, in order to say that your client was, is different in these regions, and it's not due to scanner differences. And so that's a challenge. It's something that we work on quite a bit. But what they found was that the control group was extremely important. And I want to kind of talk about what they mean by a control group. So if we have this population here of the United States, this cartoon, and we have a group of people that have suffered an injury or an experience that's developed and they've developed PTSD, should we be comparing them to everyone else in the population if we want to understand how their brain might be different or what might have changed or is currently, symptomatic and the function is different or impaired? And the difficulty is that the population is kind of comprised, let's just kind of simplify it, of kind of three different groups. One is the current group of people that have this condition. They have post-traumatic stress disorder. That's about 8% in the United States. There's another group of people that are sensitive to development of PTSD. That is, they if they haven't suffered a trauma, they would be a group of individuals that we would call a potential vulnerable population, or a population that is at risk. And then you have a group of individuals that we would call resilient, or people who may have experienced a trauma and have never developed PTSD, or have never developed a trauma, but nevertheless their neurobiology is set up so that they still wouldn't develop PTSD. And these control group studies, when they often use people that are like related. So you have PTSD and I scan your sister. Well, your sister probably has very similar genetic and neurological structure as you. And so you're going to be more similar to her than different. So if I'm trying to maximize my ability to detect how my client is different, I want to use a group of controls who don't have PTSD and have very low risk of developing PTSD, which is about 70% of the population. That number is kind of a guess. It's based on some epidemiology data that I'm aware of, but it's most people could be in that control group. But if I mix in other people that have the vulnerability to develop PTSD after an exposure, then my brain will be more similar to them than it would be to the other group. So this is, again, an example of how important it is when you're doing these types of comparisons between groups that your control group be free from those risk factors that I summarized on an earlier slide that could contribute to the development of this condition. And that is sometimes challenging and expensive, but that was highlighted in that huge Enigma Consortium study as a major reason why they believe they don't get really high levels of classification in the studies that they had. And that's in contrast to this study. So this was a paper that just came out last year. They had about 200 patients and controls, all from the same location, on the same scanner, on the same group. And they were very careful in the selection of the control group to try to maximize the differences. They were also very careful in that they studied groups of patients with similar symptoms. So they had a group of patients with dissociative symptoms, and then a PTSD with dissociative symptoms, and a group of PTSD without dissociative symptoms. Because the circuits, the networks that are involved in those different groups are different. And so they separated them out. And they achieved upwards of a 90% classification. So they used these brain networks. They were able to show that these networks were classifying the PTSD from healthy with a very high degree of accuracy individually, and also separated even PTSD from those with the dissociative condition. And each of these different networks in isolation was about 70 to 75% capable of discriminating the groups. But when they put them all together, they were able to achieve upwards of 90, 98%. Like, the algorithm's very good at telling you that's a brain that's healthy. That is not a brain that has symptoms of post-traumatic stress disorder, or has the condition, or has dissociative things. And so that's where we expect the imaging to be able to be at. And so I'm a big fan of that paper and the work that this group did to try to illustrate this. I thought it was extremely well done. And we apply, and in fact, they're using some of the software that was developed by me and my colleagues in order to do their analysis. And so it is a great application. We're currently replicating or trying to generalize that to some of our other samples to try to determine if we can get the same high level, of classification. But that's basically the where the science has gotten to. It's getting extremely good if you are careful in the methods and other things. And I'm gonna, I don't know if I think I'm over, but I would like to just kind of summarize and talk a little bit about the future. As you all know, MRI data analysis, quantitative analysis is really being commonly used already for the assessment of mild traumatic brain injury. There are multiple companies out there that provide these services. Soon, what's going to be coming is functional MRI, if it's not already been done a little bit, for mild TBI and or for PTSD and other conditions that are relevant to your, your legal cases. I put down here for your own background, these are the types of questions I would suggest you ask of your person offering fMRI someday, which would be, you normally need to go to a location that is extremely good at collecting this data. It's very suspect to motion and movement, and head movement in the scanner is a real problem generally, but really a big problem for fMRI. And you need to have a good magnet. It needs to be set up and tuned correctly. And you need to be having experts who hopefully have published in this area and are able to, illustrate that they know what they're doing when it comes to the analysis. And then finally, I think it's really important that the comparisons be done to an appropriate control group, and then it be done to a control group that's age and sex matched, because the brain really changes as it gets older. And if it's really young, it's extremely different. And then men and women have very different sensitivities to PTSD, and they also have slightly different neuronal structure. And so those things together mean that you should be comparing and looking at if you have a client who's a woman who has PTSD, you should compare her to women of a similar age that don't have PTSD. And those are just some of the background, some of the things that I think are useful to be asking your experts if they're going to try to get you to come do fMRI or do this type of work in that space. I'd like to thank you for your attention, and I have my email there. Start that way if you have questions, and I will make the slides available. I think we said I'll PDF them, and you guys can refer to them. I would like to go through and just make sure I put all the references in there, as Lynn said I have to do, so that you guys have access to the papers that I've cited in today's presentation. But I'm happy to stick around and take questions. And thank you all again. Thank you very much.
Let me ask you this, Kent. There's a question that was posted, and it has to do with the relationship or the connection between the hippocampi-related damage to the adjacent amygdala damage. Can you talk about that? I think some of the, at least I'm aware of, some of the quantitative measurements of those two areas of the brain have been attempts to correlate that to PTSD.
Absolutely.
Can you address that issue?
Sure. So the amygdala is a structure that sits right in front of the hippocampus. The amygdala is involved in evaluating anything that might be threatening or salient or important, and it will hyper respond to stimuli that like the threat stimuli that happen, and it's part of that arousal system that gets overstimulated in people with PTSD. It's extremely responsive, and it's to the stimuli. And I mentioned the military study that we did back when I was in Connecticut, and that was one of the systems that was hyper responsive. And so you would see a lot of literature out there about PTSD, about hyper responsivity of the amygdala to various stimuli, whether that's threat stimuli or other stimuli, and it kind of gets kindled. Kindling is I'm using the kindling in the sense that when you had that event and you've sensitized that neuron, you cause the sensitization. The amygdala basically is believed to just fire too much. It causes too much activity, and then that propagates up, and it causes the rest of the system to over-evaluate or over-represent the fear associated with that. The hippocampus is, of course, where memory is stored. The amygdala is a nice buffer. Essentially, information comes in, the amygdala says if it's really important, I'm shooting it straight into the hippocampus. The hippocampus stores it for your memory. And if those two things get disconnected, then and they're not communicating well, then there's problems. That small hippocampi, so if you happen to have, for whatever reason, a smaller hippocampus, that's a risk factor for developing PTSD. There are efforts. We have been involved with some of them to try to help filter. So if you know someone's going to be combat exposed, let's say you're training someone for the military, you would ideally like to not you would like to send only people who might be resilient to those experiences, because then you could almost eliminate the PTSD in the veterans. There's some challenges associated with doing that, but that's what a lot of work people have looked at, is what are the risk factors that contribute to, and neurally would contribute to PTSD. But that amygdala hippocampus, if you try to digest the literature, the neuroscience literature, you're going to see people talking quite a bit about those circuits. Most of that work is from what we call task-based fMRI. So I've presented a stimulus to a patient or a client, and they are responding to that stimulus. They're pressing a button or doing something with it. They're looking at a fearful face, or they're looking at a car accident, some probe that's designed to try to stimulate that area to see if it's too big. And so that's a common technique that's used. But the classifiers, these machine learning classifiers, these ways of classifying the brain networks, that appears to be right now the most sensitive test that we have in contemporary neuroscience for identifying different patient groups. And most, so for example, when I probe, the function of your brain with a picture or a stimulus, I'll get about a 1, or 2% of the variance will be associated with that picture. Whereas if I look, these big networks are like 30 to 40% of the variance. So it's really important how your brain, there's a lot of the signals that we're studying are relevant to these networks. These networks, we believe, are essential part of natural communication of the brain regions. And when they're disturbed through whatever mechanism, it's extremely sensitive to them. And that's what we see.
There's also been, I'm sorry, I didn't mean to interrupt you
No.
if you were finished. There's been a question by Richard Alexander, and I believe it has more to do with the use of DTI for TBI evaluation. It may be part of your machine learning algorithm for essentially for PTSD, but the comparison of right to left when you're comparing FA values on a DTI.
Yeah.
Can you talk about that and what its significance or importance is?
Right. So it's become more common, and there's been quite a bit of academic, interest in this, and that is brain injury is it's the rule is that it's only on one side or the other, or it's never symmetric is the other way to say it. So if you have an injury to the brain, a rotational injury or any other kind of thing, it's never both sides are perfectly injured. So what you can do statistically is analyze the difference between hemispheres. And, if you have a little, hole, for lack of a better term, in one side, taking the difference will help to identify, that's there. And it reduces there's a lot of value in doing that. One is it reduces what's called your multiple comparisons problem. So instead of analyzing, let's say, 1 million voxels in the brain, by doing the difference, I'm only analyzing 500,000. And so that allows us, that it's more powerful. It's potentially more sensitive, to injury. And it's a technique that is, it's very common. Obviously, the only downside would be that if there was a bilateral injury, you would miss it. But again, because that's not the norm, that's very, very, most neurologists would say it almost never happens. It's a very common technique to do this asymmetry. The asymmetry is also, though, usually there are normal asymmetries in the brain, right? So left hemisphere often has more connective tissue than the right hemisphere, because that's where language is. And we have a lot of fibers that are important for connecting our speech production and our speech comprehension. So if you do a difference, you're going to see asymmetry there that's just naturally occurring. So you still need to know if that's natural or is that abnormal. And so you're still going to want to reference a database, and you're still going to want to say that this is now, this is normal asymmetry, and here's an injury. TBI is a very, very challenging, but also very interesting issue for us neuroscientists to study, because it can be any size and it can be any shape. And that's very challenging to try to figure out where that is. That's one of the reasons why we moved to these machine learning classifiers, is because they don't care, and they analyze all of the data, and they don't make any assumptions about the data, its shape, and they can still find where these areas are that are different. And so we really like that. And so it's been one of the bigger advances that's happened in the last 7-8 years, I would say. very good.
And let me ask you, this is a question as you were going through and talking about classification rates of approaching 90. One in the last paper you
Yeah,
referenced was 98%. When I think about that from a lawyer's perspective, I often flip it because I'm going to be talking about error rates and adopted
sure,
analysis.
sure.
Tell me, what is the relationship, if anything, between classification rates and error rates?
Yeah, so they're synonymous, really. I mean, an error rate basically says how often do I get this wrong? So you're going to combine what we call sensitivity and specificity. And so the algorithm that we were just talking about was extremely good. 98% of the controls were correctly identified as controls, and two were misclassified, probably as a patient in that example. And
Okay,
then some 84% of the in this study of the sample was, or 88, I think it was, of patients were correctly classified as patients, and some were classified as healthy. And so, how can that happen? Well, there's lots of different reasons. There could be sources of noise, of course. There could be that the patients who classified as controls were not that symptomatic, so they weren't that different from the controls. It could be that normal variation, the algorithm that was used in that might not have been, developed on a big enough database to get a representative sample, right? So
yeah.
there's a variety of different things, but I would say that, from a paper publication perspective, that's an example of, I mean, I would be overjoyed if my lab's classification work was always that high. Like, that's extremely good, and it just means that they've done a very good job. I mean, and assuming, and I've obviously read the paper in great detail, and so we're very confident that they've done everything correctly. And so then it's an example of, I think, how well it can be done, and so it's really good.
And I also wanted to talk to you about, let's say, the first paper you referenced, you had classification rates of down near closer to 50 to 56, 50 to
Yeah.
60%. That happens to correlate with some of the classification rates I saw in some neuropsych testing, where you essentially end up with a coin flip. I mean, it's possible
Yeah,
that could be refined just by getting out the variables, but
sure.
that one's going to be a hard technique to pass over.
So absolutely. So I think the differences are there. Well, so we can talk about neuropsychology, neuropsychological testing if you'd like as well. But I think what the nice thing about the Enigma paper, the big study, was that it showed that some techniques are not sensitive to TBI, like quantitative MRI was not
Yeah.
sensitive to PTSD. And so it wouldn't be that helpful to pay for a quantitative MRI if you're trying to study PTSD. They showed that the fractional anisotropy, the diffusion data that you guys we use for TBI, that's not that dispositive of PTSD either. It was the connectivity that got 78%. And they used a different type of connectivity, different math in what they did. And we would academically debate with them about which one's better. And so the paper that I sent you, I believe, used the best method, the most robust method, and I think their results proved it. But I think what they're both saying is that this functional MRI is exquisitely sensitive to symptoms, cognitive affective symptoms that patients are experiencing. And so if that's your patient group, then it comes down to your control group, and you should be able to detect them. I mean, if your patient, honestly, I mean, it's just like people always ask, I mean, if you can quantify the symptoms by talking to somebody, then I should be able to quantify those symptoms in the brain.
Right.
And it should be reliable, and we should develop tools that allow us to be able to do that. And then, that helps to, we haven't talked about like confabulation or other types of concerns, but it could be obviously that some of the patients in some of these studies are treatment-seeking individuals, but they're really not that symptomatic, and so they're classifying as healthy.
Right.
And so they kind of exacerbated the symptoms, or they said maybe they're enjoying the benefits they're getting by reporting that they have those symptoms, for whatever that might mean. And so the algorithm might misclassify them, or might classify them as a control when they are, because they're really not that symptomatic.
Okay.
That can happen. So people will ask, a good expert would ask, how do you know if they're faking these symptoms? Well, we don't. I mean, someone could pay me and I'd go do it. I'd go scan a whole bunch of actors pretending to have PTSD, and see if the algorithm can discriminate them from real patients with PTSD. maybe they can fake a clinician, right? You go have a bunch of actors, train them to say this is what PTSD is, and then go report that, like they do in medical training. They'll have people go in and fake the issues and symptoms and report them. But if I scan their brain should classify as healthy. And so those are studies that could be done. But I think that as long as the patient, if you have good clinical assessments, good testing done, a good workups done with the events and family members telling you everything that's happened, the brain data can be another really helpful piece, to help you make a strong argument.
Well, I will tell you from a lawyer's perspective, listening to this and listening to the research and where it's going, it's really exciting because, what is the primary defense against a PTSD case? Well, it's all subjective. Those are symptoms that are being reported. We can't test those symptoms, but essentially, if you're looking at the connectivity of the brain, you are testing those symptoms because you're looking, okay, here's a control group with verified PTSD. Here's what their connections look like. You put it through the machine learning and you say, when you look at all these different things with a 90 to 98% accuracy, we're putting these people in the right place in terms of PTSD or not.
Yes. No, it's extremely good. And I think that that's a testament to all the work that's been done to try to quantify and assess the symptoms. And then, all the latest advanced, machine learning and work that has developed to help us decode this brain data. I mean, there's a tremendous amount of effort that has gone into developing these methods to make them robust and reliable. And not only robust, reliable, but completely reproducible. Push one button in my pipeline and it'll give you the same answer every time. And so there's always, like I said, I don't want to make people think it's really easy to do this because you got to collect good data and you got to analyze good data. And if the culmination of that leads to the types of papers that we kind of highlighted today. Yeah.
I've got a question from John Evans. It's, what if you have a client has PTSD, controlled substances as a result of that? In other words, I think I'm interpreting, and if John type it differently, if I'm not interpreting it correctly, you have PTSD and then you have the self-medication with controlled substances. How do you distinguish that client from one who had controlled substances issues to begin with that may create some of the same issues as PTSD?
Of course. So it's more of a challenge. So again, if the patient is self-medicating by taking, some psychoactive substance, could be smoking pot, could be doing anything, then ideally what you would do is the client would be abstinent and let those things wash out before you did an MRI scan of them, so that you could say that they were clear of those substances as it might relate to the scans that were done today. Sometimes that's more difficult if the drugs stay in the system a very long time. The other thing is that, substance use is a risk factor for developing PTSD. So if the client was doing drugs before they suffered the events, and then they continue with that's just something else that, would need to be dealt with. We do have reference databases, controls that are no PTSD, but have substance use, and so you can compare them and see if they differ from those groups as well as other healthy groups. So every time you have these, what would you call them, comorbidities or other, things going on, it just becomes a bit of a more challenging question to help make sure that the interpretation of the brain imaging data is relevant to PTSD and not something else. But that has to kind of be done in a different lights. Neuroquant began with the hippocampus.
Yeah.
Sure.
You want to do that question, or Lynn? I don't want to. I noticed
if you can answer it in under a minute, then yes, because then we've got our next couple of partners. We've got Blue and Cody to come on and talk to everybody.
Here's the question. Neuroquant began with focusing on the hippocampus. Historically, hippocampal atrophy is often identified as large temporal horns. Rarely have I seen anyone call amygdala damage, but I see a lot of atrophy near the amygdala. Is that not being called when it should, is the question?
Yeah, I mean, Neuroquant was originally, the software was developed from what's called FreeSurfer, which we use academically all the time. That's the commercial version of it. And Neuroquant was specifically kind of developed and tailored for measuring the hippocampus, which is one of the most common structures for dementia. And so it was really valuable and useful for the quantification and prediction of whether or not someone's going to have mild cognitive impairment or more severe impairments like Alzheimer's. But the hippocampus does many things, and so it's definitely useful. I believe NeuroQuant also quantifies the volume of the amygdala. The amygdala is as a structure that could be hugely variable. It's very rarely diseased, if you will. So the amygdala volumes are usually very stable over life, unless you have something called like Urbach-White's disease or a few other conditions, very rare. But generally, I think that what happens is the connections between the amygdala and the hippocampus, primarily because the hippocampus atrophies and degrades, get short-circuited, for lack of a better term. And so then you get people with all sorts of failed memories and confused memories and other things because the amygdala might still be sending the same input, but the hippocampus doesn't know what to do with it.
Got it.
Okay, so Jamie, we're going to do our last couple of partner sort of talks now, and then you've got the rest of the time. Thank you.
Right.
Absolutely. This has been incredible. And I love hearing all the questions from everybody. Please keep putting them in the chat box and we will be answering them throughout the rest of the webinar today. But for now, quick break because I wanted to bring in our good friend Blue coming in from Arizona, or that's what I thought. And he is going to be sharing with you guys all the great things that they do over there at HMR. And as you know, this is a company that is very dear to us, and we are so lucky to work with such great companies who are really our friends. You know, they know so much about things that can help you guys in your cases, and we're just blessed to work with them. And they are the reason why we're able to continue doing all these webinars for you guys. So thank you for supporting them. Blue, if you don't mind, tell us a little bit about what you guys do over there.
Awesome. Thanks, Ginger. And always a pleasure to be here with you guys today. Lynn, it's great to see your face. Hope all is well. Dr. Kent, wonderful speech today, man. Great talk. A lot of really good key points. Jamie, also good to see you, sir. So who is HMR? So HMR, we are the premier funding source for personal injury and plaintiff law firms nationwide. We do specialize in catastrophic injury cases, traumatic brain injury, spinal cord damage, amputees, the full gamut, right, of catastrophic. There's 3 different funding sources that I'd like to go over briefly today that we can help with. First of which is, and it's become huge as of late, for experts, life care planners, video recreation specialists like Cody, who's absolutely amazing. You guys are going to meet him in a minute. And that is case cost funding. So to get the experts you need to prove up your case, show up ready to go, that can be expensive. So if that's a heavy lift for you, for the firm, depending on your caseload, feel free to reach out to me. We'd love to step in and help you with that. The second of which funding is going to be medical. We operate medical funding in 39 states currently, and I always like to mention that just to let everyone know that we do work with providers nationwide, all the sorts of providers, right? Last but not least is going to be the pre-settlement piece. This is a tough time for your client, right? Maybe they need to pay their mortgage. They have life that they need to pay for and live. If that becomes an issue, feel free to reach out. Love to step in, help out, and get them going. But again, it was a pleasure seeing everyone. Kent, you will have to make your way out to Scottsdale soon, my friend. I don't know if you are aware, but we have all the golf out here.
I'm aware.
So we can make it a business trip, and just bring your clubs in case.
Will do.
All right.
Absolutely. Thank you.
All right. Thanks, everyone.
Hey, Blue, I keep telling John Romano that we need a seminar out there. So let's keep working on him, okay?
You totally should. And
And then we can all
I'll keep bugging him on it too.
All right. Thank you so much for everything that you guys do. Please put your information in the chat box. And again, if anyone has any questions for Blue, don't hesitate to reach out to him. Thanks for being here with us. And now it looks like Let's see. Aaron is with us. I am so excited. Now, this company is so also very innovative. They're doing exciting things, and he's going to tell you a little bit more about some of the AI technology that they're using in jury trials and also with the jury members as well. But Aaron, it is an honor to have you with us, and I know everyone's excited to hear what you guys do too.
Thank you so much, Ginger. It's always a pleasure to be here and be with everybody. Let me just get started and share my screen with just a little bit of a summary of what we do. And what we do is, if any of you have ever done focus groups, you're going to love us. And if you haven't done focus groups, you're also going to love us because we've created an AI solution that does sentiment analysis of our panelists who are engaging with your opening, with a story. And we make it really simple. We have you tell a story to us, whether you record a 5-minute, 10-minute video, or you jump on a Zoom call with us and we record it with you. We then take any demonstratives that you might have or related files to the case, and I'll show you an example in a moment. We'll do all the editing and we'll create this movie trailer out of it. We'll then deliver that to 100 panelists. So this is a big data study, usually 50 men and 50 women. And then we get the data. We track them as they watch your story. We're capturing their emotional reactions on how they're reacting. We're interpreting that data. And then after they finish watching your story, we ask them a series of survey questions, depending on what your objectives are for the testing. Could be liability, it could be evaluation, or a host of things. And then we report it and give you that data so you can prepare a strategy, or you can leverage this reporting that we provide to opposing counsel, to the carriers, or to the mediator to help negotiate, or even, again, use the interpretation to strategize for trial. So as a quick example, I'm going to share my screen again, and I am going to pull up, let me just get that organized here. I'm going to pull up an actual study of a TBI case that we tested, because I know that's what this study's about, and I promised Ginger I would make it short today. So I'm not going to go through the whole thing, but this is a dashboard. Attorney sees a dashboard of their results. So this is the results, and we have multiple sentiment maps on the left side, including survey results. This was an accident. I'm going to play a little bit with the attorney speaking while we overlaid some of the images. And I'm going to just scroll through where he talks about different
And what I love is how easy this is to use and look at, Aaron.
I'm just going to wrap up. I just wanted to show you these pink and blue spikes and dips represent the emotional reactions, almost like an EKG, moment by moment, because we're tracking our panelists through the front-facing camera of their computer or phone, which they give us permission to do. We have a nationwide panel of over 30 million people participate in our surveys. And when you have this kind of friction, it means getting a lot of angst, which means the audience is favoring the plaintiff. So that drives them to survey questions that they answer. We have multiple choice and open-ended, but I'm just going to show you one quickly about the case valuation. And we ask them a series of multiple choice answers to answer. And you can see how they voted, and you can see that how it trended upwards on 2 million plus. And so that's the end of my presentation, because I know I'm short on time, but I'm sure Cody's going to have a lot of fun talking about, TBI and PTSD and animations. And again, thank you, everybody. And let me tell you something, the best way to work with us is just pick up the phone, email me, tell us about your case. Let's have a 15-minute call about your case and see how we can help you. We just actually got update just today where somebody had an offer of $53,000 and they used our data to leverage it at mediation, and they got a $1.6 million final offer. So that's a 30x over the initial. Anyway, I got lots of stories to tell. Please call me, reach out to me.
And that is
Thanks so much.
incredible, Aaron. And I know you're working with so many of our good friends, not only John, but like Keith Mitnick, Ilya Lerma. I mean, so many amazing people that are getting these multi-million-dollar verdicts. Be
Yeah,
sure.
don't forget Don't forget Dino Colombo too.
Oh yeah, he's getting one after the next. Be sure, by the way, to put your website in the chat box too, because I want everybody able to check that out. And then I'll make sure I email everyone's a video of what you guys do as well after the webinar. But yeah,
Thank you.
speaking of Dino Colombo, if anyone wants to see him live in action, we are going to be doing our Texas seminar again. It's our second annual deposition seminar, which is going to be November 7th through the 9th. It is going to be so much fun. And we've got obviously John Romano who's coming. We've got Satch Oliver, who his book was just released a couple weeks ago, Depositions Are Trial. So anyway, definitely check into that program and you can come hang out with all of us and learn a lot. So thank you so much. We appreciate everything that you do, Aaron.
Thank you, everybody.
And last but not least, before we get to Jamie's presentation, I wanted to bring in Cody Roberts. And Cody, I have been hearing from you all day, every day, from everybody. And I love how you are getting across the nation working with everyone on these amazing cases. And they are so proud of the work that you do and the quality. I mean, I'm hearing doctors now, right, that are literally praising the work that you do. So anyway, I'll let you take it away.
Yeah, thanks, Ginger and Dr. Kiehl and Dr. Kiehl and Dr. Holland. No, it's really great to be here, and thank you, Connectionology. And so I just wanted to show you just some fun stuff on the limbic system. One of the things that Dr. Kiehl was talking about was objective data. And that's like the biggest thing with PTSD that I'm always asked as a graphics guy. And you may say, well, why as a graphics guy would you be asked that? Well, if you have to illustrate it, then you need some kind of objective, tangible something, right? Otherwise, it's just going to be, this idea of garbage in, garbage out regarding the demonstratives. So a lot of times beforehand, actually, before Dr. Kiehl gave his brilliant presentation on the objectiveness of PTSD and how we can start quantifying this stuff, what we would do to really kind of keep it simple is, and I hope you can see my screen, but we would, this is the amygdala, and we would have doctors point to portions of the brain and talk about specific abnormalities. And so we can, on a demonstrative sense, from a demonstrative standpoint, show atrophy and, that you got the hypothalamus and then the hippocampus. And so really, like, when you're actually, and we've got 3D models and stuff too, when you're showing people demonstratives and then you're talking about it, it becomes much more real to them. And then we've got this abnormal items too. And so they can just show the abnormalities and things like that. But what's really interesting to me is the quantitative data. And so we do a lot of TBI, hemorrhaging, right? That is quantitative because you can see it. And so that really interests me, Dr. Kiehl, what you're doing. And so congratulations on all your work, and I can't wait to see it in action.
Thanks, Corey. Thanks, Cody.
Anytime.
Right. Thank you so much, Cody, and be sure to put your information in the chat box. And thank you again for all that you do.
Appreciate it.
All right, Mr. Holland, I'm looking forward to your presentation. This has been a wonderful conversation so far.
Well, let me see if I can set this up and find it. Let's see. There we go. That. All right, I've shortened this presentation up a bit, so let's see. It's going to take just a second to load. Let's see. Allow. There we go. All right, I want to talk to you a bit about, what do you do when you got a PTSD case? It comes in, and what do you do to prove it? And let me make sure this is working. Let's see. Ken, do you see a? Is my slide as a background right now?
Yes, I see it. Yep.
All right, good. Now I just have to figure out how to advance it. Let's see, maybe that will work. Sorry, I'm trying to get my Zoom squared. There we go. Okay. Now I've got where I can see what I'm doing. When you have a PTSD case, it comes in. What do you do with it? Well, it's not terribly different from the metrics of any other case. The difference gets into how you prove it. But you got to know what you're proving. And you also have to know, because the value of a PTSD case has changed dramatically. I mean, I remember doing my first PTSD case in 1994. And it was for an engineer who'd gotten injured when his locomotive ran into an 82-ton generator and it turned over. And he had all the things that Dr. Kiehl was talking about. Well, the value of that case then was 6 figures. The value of that case now would be easily multiple 7 figures because it absolutely ruined his life. Now, you've got to have a DSM-5 diagnosis present, and I got to tell you, when I first started proving PTSD cases, there was really little more to go on than pulling what was in the DSM-3 up and making a checkbox next to the symptoms and having your treater sit there and go, well, he got this one, he's got this one, he's got this one. And that was the amount of dynamics we were putting into PTSD cases, because that and the BA witnesses, that was essentially what there was to prove. But, you know, I keep hardboards, I keep graphics of the DSM. I still think it's a really good tool. I still think it's a really good tool, particularly for clinical diagnosers. It's a great tool for DMEs and defense medical examiners, because they will admit it's the diagnostic Bible, which is about as close as you get to proving it's authoritative. And then you walk them through and you say, he's got this, he's got this, he's got this. And there's one local Florida, very well used, and he's really a pretty good doctor. I walked him through the checklist on a PTSD case, got him to admit it was a diagnostic Bible, and his testimony that he didn't think our client had PTSD became the subject of a Dauber challenge. And it was the driving force between settling the case, or behind settling the case. As with TBI cases, you've got to have a thorough medical chart, because any prior trauma they're going to go to, and it's not such a bad thing to have a prior trauma in a PTSD case. I tried a case, or we prepared it, and we're going to try it, for a locomotive engineer who in a 2-year period had 3 crashes. We were trying the case on the last crash because the first 2 had settled. And what you find out through the medicine is there's a lowering. In fact, I had a psychologist out of New Orleans, or psychiatrist, who told me the ability to handle trauma is like a coffee cup. Every time you fill it up a little bit until sooner or later it overflows. And that's what happens when you get PTSD. You're in the overflow phase and it's not going to go back. Proving PTSD, well, here are the tests that are typically used. There's a TSI, trauma symptom inventory. Also beware, there are some DMEs that claim that they're validity measures, which are really good in the trauma symptom inventory, and they're not. The validity measures are pretty poor. There's a clinically administered PTSD for DSM-5, which is also called the CAPS-5. It's a test that is used by psychologists to try to, use a metric test. There's the MMPI-2, MMPI-3. PTSD often produces elevated validity scales, and that's part of the process. You end up with clients with elevated amygdala reactions, and they end up with elevated PTSD scales because they're subconsciously letting you know how they're feeling in the moment. There's a great, he's actually out of the University of Alabama. I'm not promoting my alma mater, but there's a Dr. Stanley Brodsky who's done a bunch of publications on the applicability of these tests. And I would encourage you, if you have PTSD, particularly with a neuropsych or a psych DME, read some of Dr. Brodsky's work, because it will help undermine many of the parameters or the opinions of a DME. I like to, in today's world, particularly given Kent's work, I'd like to tell a jury that a PTSD is a physical brain injury. There's some advantages I'll talk to about in a moment, but when you can prove changes on an fMRI, when you can prove differences on an, when you can prove it, that there's a network change, that's physical, and that's not fakeable. And that's why I think the work that Dr. Kiehl is doing is going to be revolutionary in the proof of PTSD cases. The witnesses that tie it in together are essentially critical. You cannot try a PTSD case without some good B&A witnesses. You've got to talk about the social withdrawal. You've got to talk about the aggravated reactory responses. You've got to talk about the triggered reactions. And I'll tell you in a moment a case that I had, I think it was about 20 years ago. And it was a PTSD TBI case. And the B&A witnesses became critical. And one of the most critical B&A witnesses was the son. And it was a fellow that got hit by a locomotive in a local railroad yard. He got found trackside with a pretty bad case of PTSD, a pretty bad case of TBI. And, that was back in the day when MRI DTI did not exist. So we end up really leaning more heavily on the PTSD case. And some of the storylines that were coming out from his family were, here's a man who worked 2 jobs, one on the railroad, raised a family, was there every weekend, took his kids hunting. And after, the son had to pull dad off of PTSD dad, off of mom, because he had a reactoid response, and she was the recipient. And that was the most compelling evidence in the case, is this big change of having a reactive amygdala and a prefrontal cortex that wasn't working to moderate the reaction or to stop it and say, oh, I feel this way, but I'm not going to act this way. And that, coupled with the doctors explaining what was going on with the TBI PTSD interchange, was incredibly effective. What is the defense? What are they going to do with these cases? It's essentially the one defense. Your client's lying, your client's faking, your client's lazy, or the most recent one I found when I'm starting to ping the DMEs on whether the PTSD exists, they'll say, oh yeah, it exists. But guess what? We can fix it. He just needs the right treatment. So I see a lot more DMEs now accepting the diagnosis, but saying it's no big thing because it's treatable, and if they just get the right treatment, the right docs, it's going to go away. Proof considerations. Why I also like to prove it as a physical injury is I think it at least gives you an argument. If you don't have any other physical injury in the case and you're just in a pure PTSD case, I think it gives you an argument that it falls into the classification with the rest of the personal injury world, i.e. it's not taxable. Because if it is a pure psychological injury, the IRS is going to come down and they're going to basically tax your client on the verdict. So your client's going to pay your fees, and he's going to pay tax on the gross verdict. And that doesn't leave a lot of money left for the client. That's another reason why I think it's essential we start thinking about these cases like physical injuries and not just pure psychological injuries. Compensation. I love focus grouping. I love it for value, and not that I believe the value that a focus group is going to give me, because I don't think that's a good predictor. But it does give me a comfort level in what to ask for. And I think if you start talking about these cases in terms of the functional changes within the family, the functional changes within the social relationship, and you start, and I love, Fox AE's presentation on the brain, because I think illustrating a PTSD case with a hyperactive red firing amygdala and talking about its reaction elsewhere in the body and the brain is a graphic that I really want to start working on for these PTSD cases, because I think it's very effective. But at least in the railroad world, where these cases are pretty common, seeing 7-figure verdicts is not uncommon anymore. In fact, it's more common than a six-figure verdict. And so part of it is just having the courage to ask for it and having the wherewithal, particularly with Dr. Kiehl's work, of how to get there and how to prove it as an actual physical injury, damage to the network systems, instead of just relying on a checklist with the DSM-5. And Kent, with that, I'm finished a little bit early on intentionally, because I want you to talk to us and tell us about, and I've got some opinions as well on where we go from here. What is it, let me figure out how to stop the share on my screen and get rid of this. And then let's go to and talk about that. Let's see. All right. I also speak on technology, but somehow I can't figure out how to turn share screen off.
It might be on the other monitor. Mine jumped to my dual monitor setup, but
It's probably hiding. Let's see.
there you
we
go.
go.
Yeah.
I think Ginger probably fixed it in the background. So anyway, I love what you're doing. I love the fact that it's really science that is going to help us prove PTSD. But short of me having 20 PTSD cases in my till, which I don't currently have, and putting them on a plane to Albuquerque, New Mexico,
Sure.
to test it on your monitor, what's it going to take? Because we essentially have a science and a technology that is not readily commercially available.
You're right, and I think that we've talked about this extensively, as you know, and so I believe that there's a need for it and there's value in it. We just need to find, we need to a team, a group, a company needs to curate a data set, a database, and then potentially, send new clients in. The challenge is obviously that the first ones are expensive, and as it gets more automated, it gets less and less expensive. It's pretty new stuff, so you have to. It's not a trivial thing to do. So I think it's going to just take a little bit of time, and as these techniques also begin to be more commonly used, and there'll be more people in the marketplace looking for jobs or consulting or starting other companies that tries to leverage and do them. And so just like what's happened now in the TBI for diffusion, I mean, initially there was maybe one or two companies, and now there's probably a half dozen or more.
Right.
And so there'll continue to be one, and some will flounder and fail, and the good ones will come to the top and keep doing well. So I think that one or more of those companies, we've talked to some of them, they could conceivably try to start offering these types of tools, or this type of a test. And again, I think the challenge with fMRI, I think it's more difficult to implement than diffusion on a scanner. It's time. So you have about 10,000 times as much data is being collected. So you need to learn how to ship it, move it, analyze that. Motion is even more of a problem. I don't know if I can say more. It's just a huge problem. With all quantitative imaging. And so there's just those logistical issues. They're not that different than the diffusion for TBI. But there is the other thing that, I don't think many people would debate today that diffusion isn't very useful for detecting TBI. I mean, there's thousands of papers.
Right.
There's still probably only a dozen or so, papers out there about the accuracy of this resting state scans for TBI or for PTSD. And I think so the literature needs to continue to mature. And I think that will then eventually lead to someone developing it. As you said, I'm interested in these things. I would love to help. I would love to do this work. I just, I balance my other day jobs, and golf with doing this stuff. And so I think that, there should be a good test case or two out there. I will tell you guys something that's really interesting. So on one of the other things I do is my educational work with judges is we teach about, artificial intelligence and how that technology and the techniques from both generative AI to the kind of AI that we use in our machine learning analysis is relevant or coming into their courts. One of the things that's come about recently is that neural data is being treated legally a bit differently. So multiple states are treating neural data like fMRI or EEG as evidence, not as like testimonial evidence. So they're trying to say that and trying to give it a protected class that is your brain data, your brain activity is your own and can't be remotely monitored or used without your full consent. So even I'll need to dig up those cases and talk to my in-house counsel, my wife, but it might be useful to try to make an argument that way that your brain activity is a physical, has been legislated and agreed to, that it's a physical measure, which might help your argument that it's a physical injury.
Right.
I'd like to think about that a little bit more. But I think that people could start to make arguments. Certainly, we know that hemodynamics are just that. They are a representation of blood and oxygenation and other changes in the brain, and they certainly are a biochemical process, and they certainly can reflect injury. And so when they're abnormal, then I think you can make a strong argument that that's a physical. I mean, these are sometimes legal terms getting confused with neuroscience terms, but
the law doesn't
an
necessarily
interesting
translate
translation.
medicine very well.
Right.
It just there's no direct correlation, and what makes sense in medicine used as a legal term all of a sudden turns into chaos and confusion. So, but I do think your work fascinates me, and its application is very, very clear to me in this field. And it's a lot, in my mind, it's a lot better than putting people down with a blood pressure monitor, a skin monitor, and everything else, and showing little clips of the triggers for PTSD and monitoring whether there's a reaction or not. That just seems to me to be a little bit of treating my client like a guinea pig. But those are just an example of some tests that have been used in the past to prove PTSD.
I mean, I think so I could challenge on that a little bit. So there are pupillary responses that can be recorded to pictures and stimuli that are very automatic and very much almost like a reflexive response. Mm-hmm. And PTSD would be a prime condition to examine whether or not the pictures that are presented might show an exaggerated response that would be indicative of we get that in TBI as well, that people have difficulty modulating their reactions. So you could, and then similar to the company that was collecting psychophysiological data, so EEG or heart rate or respiration or eye gaze, that all of those data points could be potentially different or abnormal in PTSD, and so if you were to I can see it potentially being another data point that someone might. It's just kind of like neuropsych testing, but with another metric that and another metric that's really difficult to fake. That's really difficult to. So if you test somebody with all of these different psychophysiology or EEG and MRI and all these things, and they're all showing consistent responses, then that's the physical evidence I think that you're really interested in. That helps to prove that there's something there, that it's not. They're not making up the symptoms. They're not just, they're not filling out self-report questionnaires, like they've been told or somebody said if you have, and I think it's really useful. It's hard to fake those things. So I do think it gives you another useful data point.
It'd be interesting to see, your work with the network detection through fMRI and along with physical response or organic response correlation. I think those two combined would be a pretty strong science against any defense claim of, they're malingering, or
correct.
How do we know they just didn't look it up on the internet and fill in and go to a clinical psychologist and start complaining.
And I completely agree. I think my hedge here was that if you're going to try to collect the fMRI data widely, that can typically require for an experiment, if you want to present stimuli to the subject, well, then you need projectors, response devices. You've got to have all these peripheral things established within the MRI environment that's not typically found for clinical sites. Most academic research sites do have such equipment, so did you do a task-based thing where you probed the amygdala or probed specific with stimuli? Again, that would be just a little bit more challenging to implement nationwide than it would be to implement just the default resting state scans that we talked about, the analysis of just that connectivity. So again, these are just logistical issues, but they do come up and they do require some considerations. But that's why I thought the resting state might be a little bit easier. And I got my start in some of this. I started in prison, working, in prison, but I ended up doing a lot of work on things like schizophrenia, which is another condition with a lot of dissociative states and hearing voices, hallucinations, etc. And we tested all of these algorithms and connectivity, fMRI-based things, and the algorithms are exquisitely good, 90+%. And so that's been used in a few cases. I would call it more concierge level. They were done, for capital criminal defendants. And the arguments, again, were that this is kind of harkens back to the Hinckley trial with Reagan, is that, there was an argument there that he wasn't mentally ill. And one psychiatrist was saying he was. And it was one of the first times the United States brain scans were used to help inform that he had abnormal brain structure that was consistent with schizophrenia. It wasn't dispositive or diagnostic, but it was consistent. And so that helped. And so the same thing could be true now with the more modern imaging, is that these network connectivity stuff are apparent in many other conditions, and they're extremely sensitive to them. And they also discriminate them. So to discriminate a patient who has, it used to be hard to say if someone has bipolar disorder with psychosis versus someone has schizophrenia. The algorithms are getting pretty good at differentiating them. And so, eventually, I don't want to call it the holy grail, but our goal is to try to help inform the illness and the process so that they can be treated faster and better and earlier, in order to reduce the poor outcomes. So, that's what we're doing. There's a few questions in here. I think Lyn's answered some of those questions about mindset. I think take homes from the meeting. Okay.
I see one. Can a head trauma injury like concussion or hitting your head hard lead to other brain injuries like cluster 2 disorders diagnoses?
So you mean like a personality disorder? So the answer is yes. If someone gets a closed head injury or, and it disrupts neuronal functioning in certain areas of the brain, that can precipitate, personality disorder, personality changes. The classic example here is the so-called Phineas Gage, who had the railroad worker who had the iron rod that was blasted up through his head. He survived, but changed. His personality changed. We now know through hundreds of similar patients who suffered damage to the structures right above the eyes, as well as the structures a little bit deeper in there, that when you get bilateral injury, both sides again, through stroke or something else, that will precipitate some of, for example, antisocial or lack of empathy, symptoms that could eventually end up getting a personality disorder. So yeah, so anytime the brain is injured, it may precipitate changes to personality, changes to, your thinking, everything, can be changed.
I do have two practical points that I'd like to share with the group, and it really has to do with preparing your client for deposition. Number one is consider getting a professional deposition prepper like Ilya Lerner, who was mentioned before. If I've got a very difficult client, I'll call Ilya and fly her in to deal with it because she does it better than anybody I know. The other thing is, one of the prime symptoms of PTSD is survivor's guilt. Military PTSD victims felt very bad that their buddies died and they didn't. Train wrecks, plane wrecks, Many times people lose a family member right next to them and they're alive. And if you don't deal with that in the front end, a very savvy defense lawyer is going to take that guilt and lead them into accepting some responsibility for the crash. Even though there's, from an outside viewpoint, it's not there. It can be created just by channeling that survivor's guilt. And if you deal with it at the front end, you can neutralize it. But if you don't deal with it and you get a savvy defense lawyer, it can be potentially fatal on liability. And the other thing is, I consistently call defense counsel and say, if you ask my client about this incident, you're going to get a tearful reaction, you're going to get a breakdown. And it's going to happen. I'm just telling you that. If you will just move that to the back end of the deposition and not at the front end of the deposition, I promise you, you will get better answers, more truthful answers, more accurate answers if you save that for last. And if they do not order if they don't order the deposition to be videotaped, cross-nose it and videotape it yourself. Because it's a lot more effective to play that little blurb where your client goes into tears because the defense lawyer is asking the questions than to put your client through that themselves or yourself, where you know it's coming and you're perceived as a client torturer on the stand. So those are just some tips that I've got. Kent, it has been really, really, really fun doing this with you.
Thanks, Jamie. I agree completely.
I'm
I hope it
already ready
was
for the next
useful.
webinar.
Yeah.
Kent, this is fantastic. I'm getting great comments already from everybody from my emails, and they're all happy that it was recorded. So if you guys give me a little time, I'll be able to get this up on our Connectionology YouTube channel tonight. Be sure to subscribe so you can stay in touch with all the other webinars that we do as well. And then I'm just excited to have you guys back. I mean, this was incredible. I cannot thank you guys enough. We're not leaving just yet, though, because you know what time it is. We can't do a webinar without Ted Mullis from HMR. He's going to come in and tell us who the wonderful coffee winner is today. They're going to win 4 bags of freshly roasted, I think it's still Ethiopia style is what we're doing right now. So not bad. You're going to have a lot of coffee that will last you through a lot of work days.
I thought Kent was giving away a free pair of gloves, set of golf clubs.
I have an
could
old
be-
set I give away.
That can be arranged, right, Kent?
You're gonna have to get a donation from Parson.
Well, we're already working behind the scenes about maybe doing a special Scottsdale seminar. So Lynn, we will start working on that with you and hopefully we can make that happen.
I think we ought to do an Albuquerque seminar. I get to go back to my hometown.
I know we used to do
Sure. Oh, that's
seminar.
right.
We used to do Santa Fe every single year. And I think you guys know Doug Beam, but he's like, why aren't we still doing Santa Fe? So we need to go back because that was a very special seminar, a special place. And but we will work on those seminars. And I want to make a correction. I think I accidentally said that our Texas seminar coming up in this fall was in September, but it's not. It's actually November 7th through the 9th. So if I accidentally said September, I did not mean to. It's November 7th through the 9th. The agenda is outstanding, and I'm going to put that on the website today as well. So keep an eye out for it. But I see that our good friend Ted is here to share the good news. Hi, Ted.
How you doing? How's
Doing
everybody?
great.
It's a great webinar today, so it's a lot of fun to listen in.
I think we all learned a lot. So I just can't thank enough Dr. Kiehl and Jamie and Lynn for being
Thank
here with
you.
all of us. And so who is our lucky winner today, Ted?
Yeah, so I'm excited to announce it's Brent Crumpton, and he's out of Birmingham, Alabama. So he's our big winner today of some fantastic coffee. So congratulations.
All right. Congratulations, Brent. Well, this is awesome. We will definitely reach out to him in just a few moments. And thank you again so much for popping in today, Ted, and for
Yeah.
doing these wonderful giveaways. We really appreciate it.
And Jamie, you have to be careful because if you get everybody to come here, Kent wants to scan all the lawyers. So he's going to bring
Oh, we're
Santa
gonna
Fe and
compare
he
some
scanned me
pathology.
before he married me. True story.
Uh,
So, and he wants to get everybody in that scanner. So you might have to go through a scan before you get to go.
I think
the
we ought to do
conference.
that. That would make for some interesting control groups.
Definitely.
absolutely.
I'll volunteer to do it too. I think it'd be really cool to do that. I've already done, what is it, the TBI testing that they did.
Oh, that's right. They did it at the FJA
FJA.
seminar. Yeah.
Yeah, and I thought that was amazing. So we will definitely be incorporating some of that in our future seminars as well. But anyway, I'm all for it. So let's tell John Romano and let's make it happen. All right, guys, give me a few moments. I will also email you the contact information for all of our speakers, so keep an eye on that. And then Dr. Kiehl will also be sharing his slides, and then I will make sure that you get a copy of today's webinar. So unless anyone has any closing comments, I just want to say thank you for joining us. All right, we'll see you next week. We got 2 more webinars next week that I'll be adding to our website as well. So stay tuned, everybody, and have a great afternoon. Bye.
Bye.
Good one.